This is a 44-year-old male with repeated right upper abdominal pain, jaundice, and fever. Cholecystectomy has been performed, but the symptoms did not improve. On this coronal T2 weighted MRI, we see saccular dilatation of the common hepatic duct, which is filled with stones. The stones are probably pigment stones in view of their high signal intensity on this fat-saturated T1 weighted MRI. It is important while evaluating the stone disease of the bile ducts to look at the thin maximum intensity projection images, not only the whole image maximum intensity projection and the three-dimensional representation, because small stones may be missed. It shows, in addition to the saccular dilatation of the common hepatic duct and the stones inside this saccular dilatation, common bile duct stones and intrahepatic bile duct stones. The liver shows also segmental atrophy and segmental hypertrophy or regeneration. This is also seen on ultrasonography. This is the atrophied part of the right lobe, and this is the hypertrophied part of the right lobe. The liver shows heterogeneous signal intensity and enhancement on dynamic gadolinium-enhanced MRI, with the regenerating liver and the diseased liver parenchyma showing different signal intensity and enhancement patterns. This is a three-dimensional image of the fat-saturated T1 weighted MRI images of the liver, showing focal hypertrophy of the medial aspect of segments 5 and 6. In the normal liver, this part of the liver shows concavity due to renal impression. So with this combination of intrahepatic bile duct stones, segmental atrophy, segmental hypertrophy, and heterogeneous enhancement of the liver, the possibility of a diffuse liver disease has been put forwards, and the top three here are primary biliary cirrhosis, primary sclerosing cholangitis, and of course, due to the presence of the stones of the intrahepatic bile duct stones, oriental cholangitis. However, all these assumptions are assumptions of primary or idiopathic disease entities. Here, a careful look at the pancreas on this fat-saturated T1 weighted MRI images, on which the normal pancreas has high signal intensity, will lead us to the correct diagnosis and tells us that the diffuse liver disease is not a primary liver disease, but is secondary to something that is going on down there at the level of the pancreas. On this image, we see a projection of the pancreatic head on its right side. And here we see that this projection goes to the right side of the duodenum. And here even we can see the low signal intensity within this high signal intensity of the pancreatic parenchyma, which represents a pancreatic duct system. The pancreatic tissue crosses posterior to the duodenum and joins the mother pancreatic head. So this is a case of annular pancreas, and we appreciate the same findings here on the transverse fat-saturated T1 weighted images, as I said, because of the very high signal intensity of the normal pancreas. This is the common bile duct and gastroduodenal artery at the pancreatic head. And here we see the pancreas as it forms a complete ring around the duodenum. The ring is at its thinnest part posteriorly. This is a three-dimensional representation of the annular pancreas. And the T2 weighted images add the advantage of better depiction of the pancreatic duct system. Here we see the pancreatic duct as it joins the medial aspect of the common bile duct. The common bile duct shows multiple stones. But then here, after joining the common bile duct, the pancreatic duct continuation, or let us say the accessory duct of the annular pancreas, continues in front of the lower part of the common bile duct, probably compressing it. And we can see it also in the part of the pancreas to the right of the duodenum. This is the thinnest part of the annular pancreas at the posterior aspect of the duodenum. The sagittal images are underutilized in abdominal imaging because the classical training and teaching from the old days of the single slice CT has been in the transverse orientation. I find the sagittal images very useful, particularly in the pancreas, because they represent the true transverse image of the pancreas and the pancreatic duct. We are moving to the right, and here the pancreatic duct turns inferiorly and posteriorly to join the common bile duct. But after joining the common bile duct and crossing in front of it, you see the rest of the pancreatic accessory duct that moves to the right to join the annular pancreatic tissue. And here, as it turns to enter into an accessory papilla on the right side of the second part of the duodenum. This is the three-dimensional representation of the MRCP. The stomach and the duodenum are depicted in yellow, the bile ducts in green. This is the pancreatic duct before joining the medial aspect of the common bile duct. And this is the pancreatic duct after crossing in front of the common bile duct in direction of the annular pancreas. This is the narrowing of the duodenum caused by the annular pancreas. And this is the situation as we complete it from what we have seen in the sectional images, because the MRCP has been a poor quality on this case. So the very thin fluid containing structures like the pancreatic duct to the annular pancreas here and the lowermost part of the common bile duct here are not fully depicted on this MRCP. What happens is that the narrow part of the duodenum, when it is stretched by the passage of a food bolus, will stretch on the accessory duct of the pancreatic annulus, and this will tighten the compression exerted on the lower part of the common bile duct and will cause this transient stagnation of bile in the extrahepatic and also intrahepatic bile ducts, inviting stone formation and infection, ultimately leading to biliary cirrhosis after repeated attacks of cholangitis. The diagnosis is biliary cirrhosis secondary to annular pancreas. The learning points are the annular pancreas may present by repeated bouts of bile duct disease and stone formation, which may ultimately end in biliary cirrhosis. Therefore, recognition of this disease is important before the permanent changes happen. The ring of pancreatic parenchyma that surrounds the duodenum is best demonstrated on fat-saturated T1 weighted images, on which the normal pancreatic tissue is bright, and on the T2 weighted images, which show the anomalous duct of the annular pancreatic tissue to a better advantage.